Brittany's back.
Brittany's back. Yep, Brittany's back. Well, welcome everybody. I can see folks still logging in and pouring in. But let's go ahead and get started. Yeah, let's go ahead and get started. I know the number is slowing, so that sounds about right. Welcome everybody to this DIBS AI webinar. My name is Ryan Williams. I'm the Vice President of Sales and Customer Success here at DIBS AI, and I will be your host today. Today's webinar is combining CBCT plus DIBS AI for unimaginable results. And Dr. Juan-Carlos Quintero will be leading that discussion today. Let me take a minute and let me just introduce Dr. Quintero really quickly. He doesn't know that I'm doing this, so here we go. So our speaker today is Dr. Juan-Carlos Quintero, and he's known to friends and colleagues as Dr. Q. He's the founder of Quintero Orthodontics in South Miami, where 3D imaging through cone beam CT has been standard of care for years. Dr. Quintero trained at the University of Pittsburgh and completed his orthodontic residency and a master's in oral biology at UCSF. He published extensively in peer-reviewed journals, lectures around the world, and has served as president of the South Florida Academy of Orthodontists. Today, he will be sharing his expertise on using CBCT alongside DIBS AI. So please join me in welcoming Dr. Quintero. Dr. Quintero, thank you.
Thank you.
Let's see, before I turn the time over to you, let me just take care of a couple of little housekeeping items. Feel free to ask questions of Dr. Quintero. He wants to hear feedback and input from you. We've got the Q&A option here on this webinar and chat. So either one, feel free to use, and I will monitor those, and I'll try not to interrupt the flow too much, but I might interject some of those questions as they come up and when it seems appropriate. The other item is we are recording this session, so it will be available in our support website at dibsai.com in the next couple of days after tonight. Let's see, anything else? I think that is it. So welcome again, Dr. Quintero, and I will turn actually, there's one more thing I wanted to share with everybody. So you really got to check this out. This is the coolest thing ever. This is what Dr. Quintero's website looks like. Isn't that cool? Look right there. That is a DIBS AI image, which is so cool. So I love the idea that he's highlighting this technology on his website. So anyway, Dr. Quintero, I'll shut that off and I will turn the time over to you.
Thank you.
You're welcome.
Okay, are we good? Can you see my screen?
We do. Yes,
Okay.
we show it not in presentation mode. We show it. There we go. Perfect.
Okay. Yeah, I giggled when you showed the website, Ryan, because I hadn't seen my website in a while, and that picture is it's just yesterday. But it reminds me of how I transitioned from Dr. Cute to Dr. Q. Okay, so
It happens to the best of us.
yeah. Okay, so the presentation. So thank you, Ryan, for the opportunity to speak, and your team, and hello to everybody. The title of this presentation is Combining CBCT and DIBS for Unimaginable Results. But it could have a different title too, which is How CBCT Improves Patient Care and Practice Outcomes. My email is posted down below. Feel free for any potential users who have questions about my experience or just want to talk, comments, suggestions, reach out to me. Just a little bit of background so you know where I'm coming from. So I was born in Bogota, Colombia, South America. I was raised in Pittsburgh, Pennsylvania, and that's where I went to college and dental school. And then I went across the country for my orthodontic training in San Francisco at University of California, San Francisco. And I reside and practice in Miami, Florida. I'm currently back in Pittsburgh, though, for the celebration of my father's 85th birthday. Financial disclosure, none. I wish, but unfortunately, there's no financial interest here. My interest and motivation doing this is really kind of altruistic. At this point in my life, I really want to see the specialty of orthodontics raise its level of care. So I'm happy to be sharing whatever experience and whatever I can contribute to help others. Speaking of that, so my story really begins in 1941. This is a picture of my father, who will turn 85 years old tomorrow, and I would like to dedicate this lecture to him. He has been such a giant in my life, so instrumental in setting examples and pushing me from at a very young age to always strive for the best. And this is a slide that he would talk to me. He would always tell me that the top is always vacant, the top is always empty. And what that means is we should be striving to be our best. And what's happening, I find in the last couple of decades is in the field of orthodontics is there's kind of been a race to the bottom. So you'll see here the bottom of the pyramid is very busy. It's easy to be sloppy. It's easy to be careless. It's easy to just think about like the business side of orthodontics. And I see that happening a lot. And I have no interest in competing down there for the simple reason that it's just too busy, too much competition down at that level. And as you go higher up in the pyramid, you'll find there's less competition, and the competition kind of makes it easier for you to be at your best game. But it takes a lot of sacrifice, a lot of learning, a lot of continuing education, of course, and really ultimately trying to do what's best for the patient at all times, including the technology that we offer to them. So I'd like to inspire everybody to be on the race to the top, not on the race to the bottom. Thank you, Dad. Okay, we went from 1941, 1948 was when the Finnish dentist, Dr. Quintero, came up and developed what today is known as the panoramic X-ray. So that's 1948 technology, which unfortunately is still being used very much today. My practice and religion. So I'm a sole practitioner in South Miami, like most of you. Private practice. We see about 45 to 65 patients a day, which is not a lot compared to some other very large offices. So we'd like to think of ourselves as kind of a boutique type practice, very personalized. We are probably the worst practice in the country if you're looking to get your braces on the same day as the exam. So, I try to stay away from the same day start. That's supposed to be a cringe emoji, okay? I just want to mention that because it cringes me out. So we do the three-step process, initial exam, then a records appointment. Usually we accommodate the patient same day for the records, including CBCT, and then we have the patient back for a treatment conference. So it's a little slower, but it's very thoughtful, and it really helps educate the patient. And as I tell the patient, I want to educate you, but first I have to educate myself about your case. So I do like to take my time. I think the diagnostic and treatment planning process and step in orthodontics is the single most important step in the treatment. When treatment times extend beyond their estimated completion date, it's usually because something was missed in the diagnosis and in the treatment planning phase. 1998 is when I graduated from my orthodontic residency program at UCSF. My thesis was a validation study at the time using a three-dimensional kind of volumetric cephalometric analysis. For anybody who doesn't recognize that picture, that's Dr. David Hatcher. He was my mentor, my thesis mentor at UCSF. David is probably the highest regarded authority in TMJ and CBCT, very instrumental in bringing CBCT. He also founded a company, a radiology interpretation course. A company called Beam Readers for many of you who want to submit CBCTs for radiology report. That thesis, interestingly, a year later turned into a publication at the Angle Orthodontist as part of a review article on imaging, and it kind of denoted the past and looking into towards the present and towards the future, 1999. And then what happened? The year 2000. So the change of centuries, the changing of the guard. Um, so we left really the two-dimensional imaging world, which again, we're talking about 1940s technology into what the new century can offer us. So what you're seeing here on the right is a movie from a CBCT product. It's called in vivo model from a company called Osteoid, where they do surface mapping and segmentation. So those are the two different types of imaging that are people are still using in orthodontics, right? So you can go 2D or you can go all the way to 3D. But what about dose, right? So for those who are still not using CBCT, um, you may want to kid yourself to thinking, well, it's a matter of dose and radiation, and what about that? And so at one point, yes, that was a concern, but this was a landmark, really industry-altering article published by John Ludlow, who again is the authority in dose from University of North Carolina, I believe, Chapel Hill. So iCat at the time came up with a new machine called the iCat Flex, which was able to deliver dose at a ridiculously low level. John Ludlow did the validation studies on phantoms and was able to confirm that using the iCat Flex, and this is not a pitch for any particular company, I think many of the manufacturers of CBCT are catching up. But this was paramount because it gave us kind of permission to do low dose CBCTs on all of our patients. So and you can dial the dose down to as little as 11 microsieverts. Now that's just a number, and I often ask dentists or orthodontists in the audience, how much is their dosimetry knowledge up to date? How much is a Panorex? How much is an FMX? How much is a Ceph? Well, I'll tell you right now. So a Panorex is about 25 microsieverts. Okay, so compare that to a CBCT low dose, 11 microsieverts, so that's half. So the radiation argument right there goes out the window. So it's just a matter of really being it's a business decision and an investment decision, not just with finances, but obviously taking the time to learn about CBCT because it does require a lot of learning and practice. So this is again an 11 microsievert cone beam. So the lower the dose, the lower the resolution. So you do sacrifice some resolution in these low dose CBCTs. Of course, you have the option to increase the dose, like we do so on like adult patients, TMJ patients, but on children, on adolescents, we're really not fishing for pathology for the most part. So we don't care about image quality, but with the surface mapping, you're able to see, what beautiful images, the clarity that comes up from the CBCT. So at that point, it was groundbreaking for me because it pretty much gave me permission to take a CBCT on everybody without guilt. So at that point, I traded in my old CBCT, which I was using for isolated cases, and I traded in my Panorex, and I went all in with the CBCT technology using the iCat Flex for everything. Initial images, progress images, final images. And it's helped our practice tremendously. We are able to offer, I believe, better treatment in the end, more efficient treatment. And we'll talk a little bit about treatment efficiency because that's what patients want. That's what we want. The best amount of time in braces or appliances is the least amount of time in treatment. So treatment efficiency is a big objective in our practice. Better patient-doctor relationship because we spend more time with the patients, educating them about their anatomy, about their problems and their solutions. So it's a very nice trust-building opportunity that is really hard to do with a same-day start. So this kind of forces us to slow down, think about the cases a little bit more, and then invite the patient in for that wonderful treatment conference. At which point we'll educate them about their case, including showing them a DIBS workup with the roots. Certainly, from a practitioner perspective, it's created a lot more confidence in what I'm doing, a lot more confidence in how I'm managing the case. We don't like surprises. Nobody likes surprises. So I go into these cases with better armed, better prepared for anything. Uh, Less stress, ultimately. Better communication tool, better case conversion for sure. So if a patient stays for the records and they come in for the treatment conference, at that point, I want to make sure that I give them a treatment conference presentation second to none. And it shows because our conversions have gone way up with higher revenue, higher net, higher fees. Basically, you can make more money if you're into that kind of thing, Why not? And ultimately more personally rewarding. Okay. So with CBCT, we can do both macro and microscopic viewing and imaging of the patient at once. These are just some quick benefits of doing CBCT, virtual treatment outcomes, so we can plan our cases with this in vivo model product that takes a couple days to do. We have to send it out and it comes back. But what it does is surface mapping of all the elements. So we're able to grab a tooth, move it. This little colorful 3D widget is something that we're able to use to move the teeth, to torque the teeth, tip the teeth, translate a tooth. So we can simulate all kinds of skeletal and orthopedic versus dental movements. So it's a great, again, education tool, and you can see a beautiful airway back there. So all of our patients are our treatment plan with this all-inclusive single 3D diagnostic file that's very functional, that we can rotate, we can interact with it. And so it highlights what it is that we're trying to do for patients. We're not just tooth straighteners, right? Orthodontics, ortho straight dontics teeth. Yes, that's great, but it's so much more than that. And CBCT forces us, it literally forces us to really look at the patient from a more, I guess, medical perspective, if you will, trying to make sense of all the neighboring pieces of anatomy, the face, the jaws, the joints, the airways, the teeth, the alveolar ridge, the profile, growth considerations. So once you have this tool, it arms you to do more for your patients. Other applications, of course, initially CBCT was used primarily for impacted teeth. And there's all kinds of crazy impacted teeth that you really can appreciate the position in the 2D world. Being able to track the mandibular nerve for those third molar wisdom teeth situations. We are big on referring patients for early removal of wisdom teeth. Ideally before they get their braces off around age 15, through a technique called enucleation, where you just have to find the right surgeon that's comfortable doing it, where they can just scoop out that third molar tooth bud like an ice cream ball without a root, with zero risk for nerve damage. The bone is very soft back there. So that's something that we're very big on in our practice, because those are one of the factors that we shoot for in terms of stability and long-term stability and care of these patients. Our practice is really kind of divided into two. On one hand, I treat a lot of adults that are, I'd like to say, maybe kind of tertiary care orthodontics. So I have a very close relationship with my surgeon. So we're involved in a lot of orthodontic surgical cases, total joint replacement cases, TMJ cases. We do a lot of TADs, I really rely on my oral surgeon for a lot of the care that we provide adults. So being able to use CBCTs for surgical planning, and has anybody remembered how to do cephalometrics since they graduated from school? So it's one of the great opportunities when we graduate from orthodontic school that we never have to trace a lateral ceph ever again. And so I was guilty of getting away from that for many years. But it's back. So the software we use, which is In Vivo Dental, I don't know if they're the only company that has it, but with a click of a button, maybe we'll do a couple cases. They'll do an AI automated landmark identification, and within about 30 seconds, it will spit out any kind of ceph analysis numbers that you want. So I'm back into into the cephalometric. I'm reinvigorated. I have my cephalometric analysis juju back. And so it does give me again greater confidence in my treatment planning and diagnostic step. And I love it, and I share it with the patients so that they can understand the kind of the metrics of how their faces and their jaws are built. And I just tell them like this, it gives objectivity to what we do in an otherwise kind of subjective manner. To do volumetric three-dimensional voxel-based superimpositions is wonderful. It's awesome. It's for either tracking growth or just analyzing our cases. What's happening with treatment outcomes. Airway analysis. We spend a lot of time looking at airways. I'm big on airway-focused orthodontics, airway-centered orthodontics, and I'll be the first kind of person to make fun of that because, like, what the heck is that? What the heck is airway orthodontics? Like, explain, please. Okay, so it's very simple. Airway orthodontics for me just means look at the airways, okay? See what's going on, factor that into your treatment plan because what we do orthodontically is going to affect the airways one way or the other, for better or for worse. We've been doing that for 100 years. We just never knew the effects because we didn't have the imaging. So let's look at airway systems. Let's look at pharyngeal airways. Let's look at nasal cavities. Let's look at nasal floors. Because by the way, they happen to be the floor of the nose is the roof of the mouth, and then the tipping of the back molars. And so that's a big part of what we do. But we can't do that really quickly, at the initial exam. I need time to look at this, to look at the joints. They are kind of the cornerstone of the jaw hinge movement. So I want a good baseline understanding of the TMJ on every single patient, because I don't want to get blamed for something if there's a degenerative situation going on. I want to make sure that I discuss it with the patients and that maybe we postpone treatment or we educate the patient about it. Are those condyles seated? Where are those condyles? What is the risk of osteoarthritic or degenerative processes in the future of the treatment? So it's all part of the same global management of the case. The opportunity to pick up pathology on these cases, the transverse dimension, I think it's just so vital. So that's the other part of my practice that I failed to mention. So one part is adults, where that come in just very broken. Adults come in very broken with many compromises. And so having that perspective of adult treatment where I see what it takes to help adults has changed my perspective on kids. So I'm big on early phase 1 intervention, growth modification on children, just because I've been in practice for 25 years. I've had the opportunity to see what's on the other side. 25 years goes by pretty fast, and we break down as adults. So the transverse is very important for me. The angulation of the posterior teeth. So I look at the transverse relationship of the molars. So we look for the superior convergent kind of tipping of the teeth. With these models, we can rotate around. So you see that lingual tipping of the lower posterior teeth, basically the curve of Wilson. So that has also been fundamental in changing the treatment plan, because that's another question that comes up is, okay, CBCT is pretty cool. It's awesome, but it's kind of expensive. And at the end of the day, does it really make a difference in their treatment plan? Like, how does that change your treatment plan? Well, the transverse is certainly one aspect of care that you cannot see with a Panorex or a CBCT. So getting this posterior positioning of the molars, the only way you can do that is with CBCT. Being able to see how the teeth project on the ovulus. And so this part is really useful in how it integrates with the DIBS. We're going to look at a couple cases, but being able to control the torque on every single tooth, right? So we're taught in school, we talk about torque so much. The anterior teeth, the upper lower incisor inclination, which sometimes we can pick up on a Ceph, right? if you want to just average out all the cuts, that's a Ceph, but to be able to go in tooth by tooth, slice by slice on the alveolar ridge and really evaluate how those teeth are exiting. And that's picked up on the DIBS system as well. So we'll look at a couple cases where we're able to manipulate the torque on premolars, on molars, and we all know how difficult that is to do with just bending wire on an isolated tooth in the posterior segment. To be able to identify sutures on growing children, if we're doing any kind of facial orthopedics. A lot of us are doing a lot of expansion these days. So what's appropriate? Are we doing so we want to understand the sutures and the age, the ossification of those sutures. Is the patient a good candidate for just a traditional RPE? This is an example of one. So we get good palatal separation, the younger the patient. Or is the patient better off with MARPE, the mini implant assisted rapid palatal expansion based on their age and skeletal ossification and skeletal age? Or is the patient better off doing SARPE, right? So this is information that we can only really pick up with CBCT to be able to evaluate the treatment outcomes, what is working in our hands, what is not working so well in our hands, and to really start to develop treatment kind of biases and philosophies. Supernumeraries, able to pick up with great clarity the supernumeraries and educate the patient, send them for referral to the oral surgeon. Oral surgeons love this when we send this kind of data to them. It makes their life so much easier. And then, of course, now we're in the 21st century. And so why not? Why can we not? We have the DICOM, we have the STL. Why not merge them and make this perfect marriage of data for the patients? And so this is where the DIBS comes in. How am I doing on time, Ryan?
You are right on schedule, I believe. And thanks for asking, because I do have a quick question that popped up. And
Yes.
so I'll take advantage of the break. So you've talked a lot about using CBCT. What proportion of your clients would you say you use a CBCT scan on? I'm not sure if you mentioned that.
That's a good question. So I only use them on patients who I care about. When somebody asked me the other day, okay, what percentage of your patients are you looking at airways? Well, the same thing. Only on patients who have airways. So why not? You know, when I first started using CBCT, like most of us, well, who are like older like me, you know, back in the early 2000s, it was new technology, radiation was high. We would use CBCT on isolated cases. You know, we didn't have the machines. CBCT was really only available in imaging centers. So we would do onesies and twosies. We would pick and choose those difficult impacted canine cases, send them for a CBCT, and then kind of do the workup from there. And then I started getting more comfortable with it and started sending out more and more. And what I started noticing in a weird kind of way is those cases they started finishing better than the non-cone beam cases. And I think it's because I respected it more. It was more information, it was more data, it was more responsibility. It gave me greater confidence in treating these patients. So that's when I decided that was a big part of it, especially when the dose levels came down in the industry. And so I wanted to make sure that all my patients got that same kind of treatment and my attention. So to answer your question, all of my patients.
All of them.
Yeah,
Do
because I don't even
you?
have a pan stuff machine anymore because
Okay, well
I don't want to get nauseated, right? So I stay away from that stuff.
okay. That was my other question: is are you bothering even to do a panel anymore? And
With the
yeah,
software, we do convert it to Pano because many general dentists still want to see a Pano, and so you know we abide.
you might. Gotcha. Um, Another question came up is some jurisdictions limit the use of CBC technology. Can you talk to why that is and what's changed and why that still occurs? Because you talked about low dose.
Yes,
Maybe give us a little more
I think it's
context.
just outdated information. You either have to. talk to your dental board or move to a different state, in my opinion, because that's ridiculous. Because they're really jurisdictions that are doing that are forcing practitioners to use 1948 technology that's irresponsible and not as safe. If you want to play the dose card and the dose argument, there's plenty of literature that justifies what I'm talking to you about, like the 11 microsieverts. Well, okay, that a higher dose CBCT is about 200 microsieverts, which is still not a whole lot compared to like medical grade CTs. But you know, I think it's just a matter of just educating the lawmakers and getting them comfortable with the technology. You know, laws and regulations are always lagging. What do they say? Maybe 5 or 7 years behind technology. So I think it's just a matter of time.
Gotcha, gotcha. And
Yeah.
as you've been describing CBCT, you've been describing some software and some hardware. So just to make sure we're clear, it's both, right? You've got you've
Correct.
got you've got a physical machine that does the scan, and then you've got software that does the analysis and produces the images you're showing.
That's correct. That's correct. And so ultimately, what these hardware do is they generate DICOM, right? They produce DICOM, which is a universal data set. And so all of these imaging softwares now are DICOM viewers. So there's even like free DICOM viewers that you can find online. There's more sophisticated softwares like Osteoid, because they keep changing their name. It used to be Anatomage, now it's Osteoid, but it's under the same kind of holding like company. So I use Anatomage or Osteoid interchangeably, but that's the software that I use, and the software is called In Vivo Dental, and that's the one that I've been using since, because In Vivo Dental used to come as the native software for the iCat machine.
Mm,
Yeah, but there's many different softwares now in the game, and that's the great thing about competition is it forces everybody to up their game with the
okay.
different softwares. But I think Anatomage and Osteoid are the only ones who offer that surface mapping product, which is the best deal in town. I mean, I think it's like $80 to do that, maybe a little bit more, but if you do volume, like we send all our cases for surface mapping, you know, it's like 75, $85 for it. Um, so yeah, that's a unique product.
Okay, excellent. I think that is it. Just checking real quick. Okay, please. Thank you. Thanks for letting me interject a
Yeah.
few questions there.
Okay, so we've talked about how these kind of emerging technologies, DICOM, CBCT came into the playing field, into the industry, as the doses came down and things got safer and maybe even a little bit more affordable. It just started to make a lot of sense because ultimately we are 3D objects, not 2D objects. And like the great philosopher said, to see is to know, to see is to know. And why guess when you can see, right? And so you take your time, you look at the data, and it's a hell of a lot of fun to be able to do this kind of stuff. And so the merger of that technologies is what I love about DIBS. And I repeat, I have no financial incentive with any of these companies. Um, but when Ryan invited me um, to present, I jumped at the opportunity because not to sound corny, but you know, I'm not getting paid for this. Why am I doing it? Because I do want to see this specialty of orthodontics raise its bar. Because what I'm seeing is a lot of sloppiness. I'm not pointing fingers at people. I think it's just the market. I think just people are getting um, kind of carried away and with what's easy and quick and fast. And you know, you've been in practice a long time. Um, you see what works and what doesn't work, and taking shortcuts kind of comes back to haunt you. So the best way I think to build a practice for the young people is to really do at all times do what's best for the patient. Don't worry about the money so much, and just give it your all. Have love and passion for what you do, and have compassion for your patients. Um, so that is really my motivation. If the whole specialty could raise their bar, I don't know why we're still caught up in moving teeth without having any idea where the roots are and what's going on with the roots. We won't name any kind of companies or industries, but there are aligner alternatives to braces that are removable, which we use in appropriate cases. Um, but let's face it, you could flip a tooth upside down on the computer if you want, but that doesn't mean it's going to happen in real life. So there are biological limitations to everything that we do in understanding the ridge, the alveolar housing, the forces of what we're using, the biomechanical vectors. Um, so that's why we became orthodontists. We went to school an additional 2 or 3 years, and even for the general dentists that may or may not be present in the room, welcome. Just the fact that you either have a CBCT or are interested in uh, embracing this technology says a lot about what you're striving for, right? So I think that if the entire orthodontic world could practice at this higher level and not water down the specialty, because what are we really doing? It sucks to take people's money for the treatment not to work, for 2 or 3 years later for the teeth to relapse, for no reason, just because they didn't wear the retainers for like 2 months. So I think we can do better than that. We really have to focus on a little bit more on stability of what we do. Um, so yeah, that's my philosophical talk on that. Okay, so DIBS came at the perfect time in the market when I was introduced to the concept. I had dabbled around with indirect bonding, analog, but when I heard that there was a company now that was integrated CBCT, and it was my good friend Francisco Eraso, Dr. Eraso, who's an orthodontist and radiologist for beam readers. Um, of course, very CBCT minded, being a radiologist as well. He told me about DIBS, and I immediately um, uh, inquired about it. And I remember our conversation with Ryan the first time, and when he showed me a CBCT image like this, I was all in. It was like love at first sight. To the technology, Ryan, not to you.
Yeah,
No,
thank you for
I
clarifying.
love you, man. Okay. All right. So let's look at a couple cases here. And I don't have my watch or my phone here on purpose. So you're gonna have to tell me, maybe give me 5 minutes before the time's up.
Okay, you've got 10 minutes.
Okay. So let's go into just a couple cases that I find really interesting that really kind of depict the need and the reason to use CBCT and what we're doing. Okay. So this is a young girl who came in, probably 13 years old, a little class three-ish. Um, we decided to go with braces on her. Okay. I'll show you her iOS. Again, many ways to treat these different cases. This session is really not appropriate for like treatment planning. We could do reverse pull headgear with Marpy. As a matter of fact, in the last 12 months, I've kind of changed my treatment philosophy now, and I'm doing reverse pull headgear to protract the maxilla on teenagers, even young adults, because of Marpy. And I'm seeing a point come forward 3, 4, 5 millimeters, depending on the use of the patient. So this is maybe a patient that I would have presented that option at the time, but this case was maybe a year ago or so when I first started doing DIBS with CBCT. Okay, so basically a little class three, some proclination of the upper incisors, a little crowded, kind of a straightforward, simple case. Let me get my. Okay, so Sienna, where'd Sienna go? Okay, so let's look at Sienna's case. So this case blew me away and it scared me because it reminded me, wow, it's not about the clinical crowns. When we think about a root, when we think about a tooth, it's not just a clinical crown. The tooth is an object. It's a long axis object. Why is this not working? Hold on. Okay. Can you see my DIB screen?
Yep.
Okay. So, love these intersection lines. They're beautiful. I tell patients for a human being to be able to put the bracket right smack in the middle of that intersection, we're going to make a mistake every time. A little too far to the left, a little too far to the right, a little too high up, too high low, and then the tip, but with the DIBS, we can put it right on, right? So the precision is amazing. But when we look at a case like this, and I'll show this to the patients, right? And so you can see all the horizontal lines, the perpendicular lines, and then we'll show them a final result. And so we go from beginning to end, from A to Z. Beautiful result. Teeth are very straight, very aligned. If I didn't have CBCT, I would probably accept this case, get the case back, put it in the brackets, put it in the trays, so on and so forth. Okay. But when we go back and look at the roots, let's add the roots. What's going on there? Oh my goodness. Okay. Needless to say, that root conversion of the upper centrals is dangerous. It's unacceptable. Look at the lateral incisors. Okay, so now this changes my treatment plan. So now I'm going to go in and I'm going to make some adjustments on this case, right? So for those that don't know, it's this simple. Well, you guys know how to, if you're using DIBS, you know how to move a tooth, right? So it's the same features. So what I tell patients is not only do we want straight teeth, we also want straight roots. And patients are blown away. Oh, I didn't know that you could do that. Right? So I'll go in and I'll do my modifications. And so it changes the case, right? And then I'll go back and I'll do a little bit of the movement on the canines. I don't know if this is boring people because I can't see people's feedback or faces, but it changes the game, right? When we focus on root parallelism, you end up getting results. Okay. Oh, and by the way, because yeah, I've been doing CBCT for a long time, and so this is nothing new for me in terms of wanting to see straight roots, but in my 2D Panorex days, we'd go whatever time, 6 months, then it's time for a pano to do a bracket reset, and then we do some bracket repositionings, but there's always going to be some geometric distortion going from 3D to 2D, right? So it's arguable how much you can trust the Panorex when it comes to root parallelism in the posterior teeth. I think there's been some studies that have shown statistical significance in differences in truly analyzing root parallelism between 2D and 3D. Okay, but what I quickly started noticing when I started using cone beam and doing my bracket resets at 6 months, of course, now I had a cone beam. So I would take a progress cone beam, like a mini scan, smaller field of view, and now I do my bracket repositioning assessments based on cone beam. And what I started noticing is the way the occlusion just started to suck in with marginal ridges, things that I could not quite catch just simply looking at models or in the mouth or clinical crowns. But if I just focused on root parallelism and the CEJ heights of teeth and just having faith in that system, because that's the way kind of the anatomy is built, these occlusions just started to come in together so nicely. And then it was just a matter of some inter-arch correction mechanics, whatever that took, right? Class 2 elastics, class 3 elastics, herps. I mean, that's a different conversation, a different topic for another day. But DIBS is wonderful for intra-arch alignment. And you just have to focus on root alignment, CEJ alignment. You get to do this on the computer. Patients don't talk back at you when you're doing this. It's nice and quiet. And I just go into my Zen moment when I treatment plan during quiet time, and I'll go in and I'll do these little adjustments, right? So it's a lot of fun doing this, and it's a lot of fun knowing that this is actually going to work in the mouth because you could do this on an aligner software. And okay, with attachments to Kingdom Come, you might be able to tip a root after about 3 years. Okay. if you're trying to prove something. But how about just put a bracket on the right place and have it go in the right position in about 2 or 3 months? So there's something to be said about treatment efficiency. Okay, and so then remember we talked a little bit about Ryan. I have a question for you because this comes up. How do I get rid of this red label about the GC experience? Because sometimes that comes up on my screen.
It's a good question. I'm going to probably defer to one of our support team that's on this call.
Okay.
Let's see who jumps on.
If you deselect the tooth, it should go away.
Ah, that sounds like Brittany.
That was Brittany. You know, I've learned to get smart people on this call with me, like you and her. So,
Okay.
hey,
Welcome back, Brittany.
while I've got you, so Dr. Quintero, um, how are the DICOM files added to the DIBS AI case, the case in DIBS AI?
Oh, there's a place in the submission portal just where you upload photos and STL. There's also a section there for uploading DICOMs.
Okay, excellent. Yeah,
Good,
that was a
good question.
question that popped up.
Yeah. It does take a little bit more time because your staff has to package the DICOM. Usually we zip it, we put a separate folder, and then we just upload the zip folder through that portal. So you guys have made it very easy for us and very nice.
Perfect.
Okay, so I want to focus a little bit on torque. Okay, because the mesial distal root tip is kind of a no-brainer. Okay, so how do you add torque, customized torque to individual teeth? Okay, so the molar obviously needs some lingual root torque. All right, so you go in. There's a couple ways to do it. Okay, you just select the tooth, and you have I have a 50% chance of getting this straight. Okay, oh, I got it. Okay, because I can't keep the arrows straight in the right direction. Okay, so we're adding a little bit of lingual root tip there. Okay. The other way you can, so one tooth at a time. Okay. So let's say I overdid it. Okay. If you don't want to click, 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 you can do shift. Oh no, I got that wrong. Okay. If you want to incorporate this with custom bases, then what you need to do is hit shift and torque. Is that correct, Brittany?
Yes, that's correct.
Okay, and if I torque the tooth without hitting shift, that's an assumption on your end that I will be bending wire. Is that correct?
Yes, that's correct.
Okay, okay. I kind of like to stay away from bending wire. I'm allergic to it for the most part, especially torquing molars, first molars, with wire bend. Okay, so yes, that's an important point. So you have to hit shift and then the torque button. And so what it does, it will create, well, let's put the bracket on there. Okay, a custom base. So if you really want to see the custom base, you have to go back to the existing, to the pre-treatment, right? And so you can see the gap there in the bracket base. So the tray will come just like with any other customization of, let's say, a non-CBCT DIBS case with rotations or step in, step out. It will now, you have the ability to add torque on it, but I don't know why you would want to add torque to a tooth if you don't know where the root is. So we use this all the time in all of our cases. All right.
So, Dr. Quintero, what did you do with your CBCT scans before DIBS AI? How did you use those? Was it just a super manual process?
Yes, good question. Yeah, so I would have the CBCT file up on my computer. So every operatory has a desktop with a monitor, and we have our CBCT. So I would essentially be looking at the CBCT and while I'm placing the bracket. But there's human error that goes on there. Unless you have like ultra direct visual placement, which is hard to do on the sevens and the sixes and the fives. Right, you can do a better job in the front teeth, but Okay, so I just want to, because I want to move on to just a couple more cases, or maybe one more case that we have time for. Okay. All right, so I just want
It's 10-2. So
time
if you
to.
do one more case, and then maybe I've got a couple of questions have come in, but we'll wait until you're done.
Okay. Okay, so I find this a lot. Here's this lower right four, right? Like you can't be quick about this, okay? Okay, that needs a little bit more mesial root tip. And I've had the opportunity now to see how these treatments are playing out at the end, right? When we take the braces off and I go and evaluate how the case finished with my cone beam, sometimes I'm disappointed with the lower right five. It could have used a little bit more mesial root tip. Or at the bracket repositioning appointment, right? And so before I criticize the DIBS system for it, I go back and I look at my setup. And sure enough, I missed it on the setup. I could have done a little bit better job accentuating a tip or a torque, right? But so like, let's look at this lower right five. This is something I would never be able to catch. Okay, that lower right five needs some more lingual root torque. I guess you could do some wire bending. I guess it might work. More than likely, it might overwork or underwork. And then they'll break the bracket off or break a bracket off somewhere else, and you go step down to a straight wire again. And it's just very frustrating. Okay. Oh, another thing that I notice is, for instance, rotations in and out positions of anterior teeth. Right. So a lot of times we think they're rotational issues or in and out issues, but notice how the in and out changes, of course, this is obvious, with the torquing, right? And 9 times out of 10, you'll go back and you'll see that, yes, indeed, that root needed to be torqued out. That's why that in and out discrepancy exists on the interiors. Okay, I want to go over one more case because this is really something. So this case was referred to me by our ENT. So in a place like Miami, there's a lot of good people, a lot of good professionals, a lot of good ENTs. But there's one guy in particular who's known as kind of the guru ENT in town. And so he sent me um, his daughter-in-law. What an honor, because this guy has so many orthodontists referring to him, right? And for him to refer me his family member, wow, I felt greatly honored. So Amy came in with some joint symptoms, looking like this, and a couple of people had tried to sell her on a liner system. I'm not going to mention any companies. I call it CAT, clear liner therapy. So they want a second opinion. And where'd you go, Andy? So look at this case. Okay. So anybody who sees this case, it's kind of a scary case. I could see why somebody would want to use aligners on this case, because aligners do have a good side effect of closing bites. So it's beneficial if you have an open bite, right? But when I looked at Amy's CBCT, I was also kind of nervous about the first thing we always want to do when we see an open bite on, particularly on adult that has not always had an open bite, is first thing we want to do. If I could, I would ask a question and see who answers the question, but I can't. So the first thing we want to do is we want to look at the joints. Be highly suspicious of an anterior when we see anterior open bites, highly suspicious of joint degeneration, right? Degenerative joint disease, osteoarthritis. So she has good healthy joints, so that's not a concern. Want to make sure that condyles are seated all the way. For the most part, it's pretty good, but there might be kind of an increased joint space there. So there's a potential she may, in the middle of treatment, those condyles may seat a little bit more and her bite might open even more, right? So then I go back and I just look at the volume and do my thing, right? So again, this is the in vivo nasal software. Those are virtual TADs that you're seeing there. So the treatment plan for her was to remove the third molars, place TADs, And this is a slam dunk root alignment case. Okay, yes, there needs to be some posterior intrusion for sure. Okay, but when you look at these roots, they're just screaming, like look at that first molar. Okay, it's screaming for MRT, first second premolar, because she's missing 4 buys from previous ortho, screaming for MRT, right? So we look at Amy's case. Uh, you know what I forgot? I forgot to ask for her case to be unarchived because I wanted to show the case. My apologies. I I think it's kind of late for that, but okay, let me just show you the result. And we were done like in 9 months. Okay. For the life of me, I'm not trying to show off, you guys. The point I'm trying to make here, it was precise root movement and root positioning. Yes, removing the third molars because they were fulcrums to the bite. Yes, having TADs to control our vertical. But as soon as we uprighted those roots, remember what I was saying about how the occlusions just start to sock in so beautifully with marginal ridges and root alignment and some elastic wear. You could probably get a similar result with and leaving the roots not straight, but it probably won't hold up very stable. So having straight parallel roots, of course, is going to improve the biomechanical forces of mastication through the long axis of the teeth long term. So again, if we're really thinking about long-term stability on our results, we have to be thinking about root straightness and root parallelism. So I guess that's the conclusion, that straight teeth also means straight roots.
Awesome. Dr. Quintero, if you want to try and open that case, it's unarchived and ready for you.
Oh, really? Beautiful. Okay. Okay, thank you. And there's probably a little bit of this to every single case that we treat. So if you really want to do a nice job with the occlusion and periodontal health and periodontal stability um, and treatment efficiency, reducing treatment time, reducing treatment errors. Okay, so one of the boo-boos on the dib size is sometimes because I believe you guys depend on a third party for the root segmentation. So
We do.
obviously these are not bridges that you see here. These are roots that were missed. And I think there was some confusion because the patient was missing premolars, and we may have marked off the patient's missing the fours. And so the technician on the other side, I think of the lake, if I'm not too sure, the other side of the lake. Um, they miss it. So, okay. But so then I just asked them to kindly, just fine tune the segmentation, and they did. Within 20 minutes, it came back. The roots were straight. Well, the roots were there. And so what I did in this case is just align the roots, just get the roots straight, and then control my inter-arch mechanics. So that's a separate decision, right? So DIBS, CBCT, intra-arch alignment, straight roots, straight CEJs, straight marginal ridges, inter-arch mechanics, separate story. TADs, rubber bands, wisdom teeth, orthodontic surgery, herps, you name it. There's multiple different ways of improving occlusions. Okay. And let me see if I can just bring up Amy's final cone beam. Because I remember when her father-in-law sent her to me, I was like, oh God, I don't want to mess this up. I better get this one right, diagnostically and treatment planning wise.
That looks great.
Yeah. Okay, so let's just look at the final results here. Okay. So in retrospect, yes, that lower right 5 could have used a little bit more MRT, but that was on me because that's one thing that DIBS does very predictably is express root tip based on bracket positioning. Okay. All right. So bite closure, I would say root parallelism played a big part of it. Okay. Okay, I'm happy to take some questions if anybody has
Yeah,
some.
I've got a few waiting for you here. So really quickly, what would you say? Yeah, let's do this one first. What would you say has been the impact of DIBS AI in conjunction with CBCT for your practice? Like, how did that change things for you?
Life altering in many ways, very satisfying. I'm making a lot more money. To be frank with you, why? Because of treatment efficiency. And I feel confident now estimating 9 to 12 months on the average case, whereas before, say 15 to 18 to give me some wiggle room to make up for the errors that we in orthodontists produce. Because if we're really being honest with ourselves, so much of extended treatment time is because of cleaning up side effects that we have to clean up. A lot of times with bracket misplacement, right? So instead of financing a case for 18 months, I can finance a case for 9 months with confidence, right? A follow-up my question might be, well, shouldn't you charge the patient less because it's taking less time? And my response would be, in the words of the great Ron Ronconi, orthodontist extraordinaire, is just like a business master with in orthodontics who taught me. What he would say is, "Well, I would argue you should pay me more because I'm being so efficient."
It's faster. Yeah.
And if you interview your patients, they will happily pay you more to be in braces less time. Maybe not from day one, but ask them 6 months into treatment how they feel about that.
Little upsell opportunity there.
Yeah, yeah. So and the confidence of just being able to know that teeth are gonna move the way I want them to, and that I treat and plan and diagnose the case properly. Yeah. So treatment efficiency, I guess.
Okay, excellent. A workflow question. I'm not going to do this justice, understanding this, but how do you incorporate CBCT scans into your workflow?
Oh, great question. So when I first started
Yeah,
doing this, I didn't
good.
know.
I'm glad you understand that question because I'm not sure I do.
Yeah, yeah. I didn't know like how to do it. Like, okay, because it costs money to, that's your business model, right? We have to pay for the case whether the patient accepts treatment or not. Because we're so used to submitting records for like aligner companies and they do a workup and we don't have to pay for that. So it's very nice to have a virtual simulation of the treatment outcome to be able to show the patient, and it doesn't cost us a dime, right? Okay, so but your business model is different, and people should get properly compensated for their expertise in their work. Okay, so then how do I do that? Do I wait until the patient commits to treatment? They sign a contract, they're ready to order their braces, they pay down to payment, and then order the DIBS. So I struggled with that a little bit at first, and I started surveying and interviewing some patients, especially moms. Moms are like they'll be very honest with you, and they call the shots at home many times, right? And so I asked them, when I would show them a DIBS, would this help you if you saw this at the treatment conference? Does it make a difference for you? And she said, absolutely, absolutely. And what she said to me, and a couple people have uh, have also repeated this. If I'm going to drop six, seven, eight, $5,000, whatever it is going to be on my daughter's treatment, Definitely. I want to see what I'm getting. I want to see what the outcome is gonna look like. And I want to show them that with great confidence that this is the result that we're going to get. Because our conversions are so high because of the way our workflow is, I'm not afraid um, of losing out on that investment on the DIBS workup, right? So we charge for the record. So my goal is just to cover my whatever lab costs I have, the surface mapping, the Anata model, the DIBS workup. So that's definitely incorporated in standard on every treatment conference that's going to be getting DIBS.
Okay, excellent. We had a doctor actually leave this meeting, but I'm going to read his comment to you. I have another meeting at 5, so I got to scoot. Great presentation, Juan. I've been using DIBS with CBCT for a bit now, but I learned a few new things. So kudos to you. Another question is, do you find you need to add overcorrection to your setup for more difficult movement? For example, uprighting flared incisors.
I do. Yes. The only thing you have to be careful with, or you need to see the alveolar bone and the ridge, but you have to be careful that it might actually work. And so if you add overcorrection, you have to be on the lookout for recession because we can't do a CBCT every month. I mean, I guess we could, but it's just not, I think, practical or really responsible. So I think over torquing or under torquing with the custom bases really only takes place after you've let like world to two slot. Like if you leave a 1925 NiTi in there for like an extended period amount of time, like 6 months or so, but you're going to get that anyway with custom bases or not because we use GC, which is an active passive self-ligation bracket, so it's constantly working. That torque is constantly being expressed. Yeah.
Excellent. What bonding material do you find works best?
The ones that my staff likes.
That's well said.
I really don't know. I'm not sure we're using what I think Reliance, is it Reliance Light?
Go-to?
The go-to? Yes, that's
Go-to,
it.
probably.
Mhm.
No, yeah, Reliance is go-to. Okay,
Yeah.
excellent.
Oh, that's the other part that I greatly enjoyed is not having to put braces on. I spend most of my time straightening teeth on the computer. Um, And everybody knows how it is. I'm ready to light. I'm ready to light. You got to go and you got your pressure because of light curing sensitivity. And then you got to get to the treatment conference and this other patient. Oh, that in itself, talk about increasing quality of practice and increasing quality of life. And I have all the faith in my staff that they're doing a good job with the technique. You guys have great training systems. You have a great training team, a fabulous job. I just have to do my end of the work to make sure that I get the setups right on.
Right on.
Yeah.
Excellent. Okay, so a couple of things to just bring up to this group. I'm going to add a little bit to Dr. Quintero's way he's shown you today. He's shown you an actual CBCT scan using an actual DICOM file. There is an option in DIBS AI to use an AI generated route. So some of you don't have CBCT scans, or maybe you practice in a state that has these weird limitations. You can request an AI generated route. It's not precise, right? It's AI generated. So it's taking a look at a massive amount of data and kind of predicting where the routes would likely be. But it does help with route alignment, right? That visualization is still good, even if you didn't grab a CBCT scan. So I wanted to add that to your comments. And also as you were looking at the case there and you were evaluating root alignment and how that affects the position of the crown, we do that as part of our signature series setups as well. So
Yes, I wanted to give you a shout out for that. It's a little bit money, but it's worth it. And it took like a month for feedback and interaction with your technicians. This is the way I want my cases, which basically means straight roots. But it does save me a lot. And lately, those cases of like, there's nothing left for me to do.
That's
It's
the idea.
wonderful.
That's
Yeah.
the idea. Yeah, with a standard case setup, the AI does not look at those routes. In fact, the AI flat out doesn't look at roots. But what we do in the signature series is our staff does, right? So they spend time to do what you would otherwise do, and it just makes it easier for you.
It's so worthwhile. It's not a lot more, it's a little bit more, but I think anybody who's submitting CBCT should definitely do that. You're going to get
Awesome.
beautiful setups. You'll see the difference.
Yeah, perfect. I think that is it. I think we've used up our time and our questions here. So let me just express appreciation to everybody for being here. We had a total of 31 attendees here tonight, which is fantastic. We'd like to thank you, Dr. Quintero, for contributing your talent, your expertise, and experience for all of us this evening. And thank you, everybody, for your questions, for joining us. And check out Dr. Quintero. If you want to look at this again and zoom in on something specific, you'll be able to see this webinar on our support website at dibsai.com in a couple of days. And that's it, everybody. Thanks for joining us, and have a great evening.
Thank you very much for hosting me. Bye-bye.
Thank you.